All right, good evening, everyone, and welcome back to the MyCP webinar series, where we try to bring the community up to speed with the research that's going on in the Cerebral Palsy Research Network directly from the people that are running those projects. My name is Paul Gross. I will be your host, and tonight we're going to talk about the importance of hip surveillance in cerebral palsy. And I'm very pleased to have Dr. Wade Shrader from Nemours AI DuPont Hospital in Wilmington, Delaware this evening, who is the director of their cerebral palsy program, an orthopedic surgeon, and the father of 4 children, but 2 children with CP. So very experienced. So let's dive in. For those of you that have attended these before, I do a quick sort of update on CPRN. You can feel free to tune out. It should take about 8 minutes and then we'll be rolling. So the agenda is I'm going to give that introduction and then I'm going to turn it over to Dr. Shrader. Okay, so CPRN, which is not how we refer to us anymore, was founded out of a meeting that NIH ran in 2014. And what happened at that meeting was quite unique in the sense that the organizers got together and they pointed at people and asked them to run subcommittees to move forward 5 key priorities that we heard over a day and a half at that meeting. Start a national CP registry, do more comparative effectiveness research, study the adult population, which is the largest population of people with CP, bring young clinicians and scientists into the fold, and advance basic and translational science. I co-led one of the groups coming out of that with Dr. Deb Gabler, focused on starting a national registry, and that discussion just snowballed, and the Cerebral Palsy Research Network was founded originally to do just those first 4 things, but now with the partnership with Dr. Michael Kruer, we're actually doing, to a degree, all 5, not generally advancing basic science, but translational science with his genetics work. The network was a merger of 2 core experiences. I have a 16-year-old boy with cerebral palsy. He also has hydrocephalus. And I had co-founded a clinical research network that really transformed clinical research in neurosurgery back in 2006. And on our task force, we had Dr. Gary Noritz, who ran the cerebral palsy program at Nationwide Children's Hospital. And they had a single center registry, and what was unique was they gathered the data from the registry through usual care with their patients, and that care done in the electronic medical record is what generated their data. So that was very formative. We're patient-centered from the outset, and from day one, I partnered with Michelle Schusterman, who founded CP Now the following year from that meeting, the same time we founded CPRN. So we've been working together closely. We've had several key milestones. We launched that clinical registry in March of 2016, and today it has more than 5,000 patients in it. The registry elements, the database that defines it underneath, was taken by Epic and put into their system. So every Epic site has the database, not the data, but the shape of the database. And then for the other very popular EMR, electronic medical record system, Cerner, there are forms under development at Gillette. Today, we've got 18 sites that are collecting either partial data, meaning like maybe one discipline is collecting the data, or they're collecting it for their whole population into the registry. In 2017, CP Now and CPRN partnered to do Research CP, which was a many-month-long process to get community input into setting a patient-centered research agenda that culminated in a meeting in Chicago and was published in 2018. And that really drives our research agenda. We've had some significant public funding milestones for support of the registry, both from the Pediatric Epilepsy Research Foundation and then through Michael Kruer's genetics grant for $3 million for the study of genetics in CP, which was started in 2019. We launched a community or patient-powered registry in March of 2019. We've got over 1,000 participants in that, split roughly equally between parents and caregivers of children with CP and adults with CP. But it also brings the community in, the clinical community, to participate in discussions. That registry is cross-sectional. It's longitudinal to follow people all the way from childhood into adulthood. And we have a study that is core to that, which is the study of adults and we have enrolled 200 patients. And if you're an adult on this call and you have not taken that study, I recommend you go to MyCP and do that. We've launched 4 quality improvement initiatives. This is another way to improve outcomes in addition to doing research. It's just much faster. And those were launched. And Dr. Shrader will talk about one of those, I think, in the context of his talk tonight. We've had 4 publications, over 20 academic presentations, and we have 8 manuscripts under development, more than 8. So we should be publishing a lot more. CP Now, which was developed, as I said, sort of in parallel and working with us, was founded as a 501c3 with the launch of the CP Toolkit. And subsequently, Michelle Schussman received the Making a Difference Award from the American Academy for Cerebral Palsy and Developmental Medicine in 2016. The funding for Research CP from PCORI flowed through CP Now. She followed up with a well-being guide as a resource for parents, then translated the toolkit into Spanish and then Portuguese, and then began funding research, which was core to her mission in 2018 and in 2020. CP Now was focused on wellness in addition to education and funding research. So in January 2021, CP Now and CPRN finally decided to merge and come together under the name of the Cerebral Palsy Research Network. Our mission, optimizing the lifelong health and wellness of people with cerebral palsy and their families through high quality research, education, and community programming. So what is it really? So it's 501c3 that actually the biggest effort, the biggest program is to really pull together these institutions, clinicians, therapists, researchers with community members to conduct research to improve outcomes for people with CP. Physically, it is a data center that is hosted at the University of Utah that hosts the registry, which is basically a database. And it hosts both that clinical registry that I talked about and the community registry. And then we make educational and well-being programs such as this program tonight is part of our educational series. MyCP is a core program as part of this. It used to be a standalone website. It is now integrated into cprn.org, and it's a place where you can get a personalized experience about CP. So you give us a little bit of information on onboarding, and we tell you about what information, what webinars, what books are really most germane to you. And it gets you access to things like the wellness program that we've launched in conjunction with Staying Driven. More importantly, or most importantly, it allows you to participate in discussions and participate directly in research where sharing your lived experience can really help give us the information we need to change outcomes in cerebral palsy. So just to give you an idea of like the clinical registry, the registry that I described collects data through the electronic medical record. This is just one data point, which is the gross motor function classification system for all of those. This is just before we got to 5,000 patients. And you can see the distribution of, more 1s and 2s, more ambulatory kids than, well, actually about parallel. And this is probably largely because the kids that have are more severely impacted are more likely to be seen in a clinical setting. Oops, that went away. Then MyCP has about 1,355 total members now. As I said, there are roughly 1,000 that are either a person with CP or a caregiver, but we also have a broad number of providers there, advocates, researchers, and industry people. So that sort of touches on our programs. This big wide photograph is the 45 people that came together in Chicago in 2017, which was really an impactful meeting in setting our agenda. And then on the right, you see the research team that meets every year, unfortunately the past 2 years virtually, but to really advance the work of the network. And then our core educational materials and our health and well-being programs. So the network, if you want to get the actual details, not just dots on a map, you can go to cprn.org, but you can see it's spread out across the United States and a little bit of Canada. Green pins are sites that are actually enrolling patients into the registry. Yellow pins are sites that are getting through the sort of technical aspects of that to get their forms up and running. Red pins are working on They're compliance items, and the blue pins are candidate sites that have raised their hand and said they're interested in joining the network. Okay, before I turn over to Dr. Shrader, the whole idea of CPRN was to really advance the amount of research that was going on, and this is our research pipeline. So on the left side, you have a funnel, which is where we just want to get good ideas and move them along. And then down along the bottom, you see that after, well, actually top and bottom, after a concept is approved, it moves towards application and then gets implemented, and then it executes for some amount of time. Publications come out of that. And then we take the evidence from that and roll that back into the way we practice at the site. So it's really this virtuous cycle. So you see there are these orange ovals are quality improvement projects, and the green ones are research projects. So you can see we've got a lot of activity. And one of the things that Dr. Shrader heads is our effort in hip surveillance quality improvement. So with that, I am going to turn it over to Dr. Shrader. As I said, he's a pediatric orthopedic surgeon at Nemours AI DuPont, where he is the division chief for their cerebral palsy program. He's also a clinical professor of orthopedic surgery at Jefferson Hospital in Philadelphia. As I mentioned, PI of our hip surveillance project, and he is on the board of the American Academy for Cerebral Palsy and Developmental Medicine. And so with that, I turn it over to Dr. Shrader. Let me stop my share, or you can steal the share.
All right. Everybody hear me? Paul's got me unmuted now.
You're unmuted. We can hear you.
All right. Let's see. And you can see my slides.
No, right now we can see your, we see a finder. So I don't know screens, you got to do a swap displays maybe.
All right. Well,
or you might need to.
Let me stop sharing and let me try it again.
Okay. Now we can see your slides.
There we go. All right. Great. Thanks so much for the introduction, Paul. I'm very happy to be talking with you tonight. I'm going to try to go through this fairly, it's a lot of information to talk about hips. I mean, I entitled the talk "Decision Making for Hips and Cerebral Palsy Across the Lifespan" because we are going to talk a little bit about some adults, adult CP hip care. Paul already mentioned my disclosures there, and I do talk a little bit about just kind of frame everything because my kids have had just about every orthopedic surgery that we do for our kids with CP. So as Paul mentioned, we'll jump right in and then hopefully we'll have some time for some questions at the end. During medical school, my wife was very fortunate to have our first children, and they were triplets born really, really early, born about 29 weeks. And there's just some pictures of them they were really small, around 2.5 pounds apiece, with some pretty good APGARs. And initially they actually did pretty well. But of note, all their head ultrasounds were essentially negative. Mason had one of them that was really, they told us was a questionable grade 1. We were pretty much reassured that all three would be fine with no disabilities. The triplets were in the TEMP study group. Some of you might have heard a little bit about that, or although I may be aging myself, that my children were involved in the study group. We had really good research in the past that talked about all the normal developmental milestones, but we didn't really have that for premature babies. So in the 1990s, the TEMP study group was part of a national study group to try to get normalized developmental milestones for kids that were premature. So we were very closely monitored by physical therapy. This is a classic pediatric physical therapy textbook. There they are on the covers of that textbook. So a lot of people had their hands on them very early. And because of that, we had a relatively early diagnosis for that because it was obvious that there was a noticeable developmental delay in the boys, especially compared to their sister, who was actually making all her normal milestones. So we had our own little research study group in our house there. So we had a pretty early diagnosis well before the age of 1. And then I'll come back to this a little bit about some of our road as being parents of children with CP, especially in terms of hip decision making. So we know that CP is a static brain lesion. It's a static brain issue that happens around the time of birth, usually because of some type of insult where the developing brain has trouble getting some oxygen. And prematurity is a very common cause today, but there's other reasons that cause CP-like issues. There can be some genetic issues. Paul mentioned our genetic studies. There can be infections. There can be congenital brain problems. But it's important to note that the musculoskeletal or the orthopedic aspects of CP does change over time. And that's because of the growth and the other issues that happen to our muscles and joints as we go through childhood and into adolescence. And it is the most common childhood onset disability. And there's just another picture of them, and then picture of all three of the kids in a single baby swing. That's how small they were. Paul mentioned the GMFCS system, and I have to say that when you can't really talk about hip surveillance unless you talk about this classification system. And so I want to briefly just kind of make sure that we're all on the same page about that. We use this classification system to really communicate to one another. We use this to really kind of classify what the function of a child is, not to try to pinhole them into a certain insert category or function, but it's really just a descriptive terminology. And before we had this system, the descriptions really weren't that specific. So it was really hard to try to do really good research by grouping kids together. And more importantly, we didn't really have a great way of trying to predict natural history and try to help educate and how to help, inform parents how to make good decisions about what's the right things for their kids. So this is one of the most important things that have come out in CP care and in CP research really in the last 20 or 30 years. And it seems kind of silly that a classification system would do that, but it really has revolutionized how we talk and frame things. So I'll go through this really quickly. It's valid because we know it's based on some standard physical therapy assessments and scoring that therapists have been doing for 40 years. We know it's pretty reliable. We know it's pretty stable. Once a child kind of goes through their development, they typically will plateau at that level. So once we know where they are, especially by the time they're age 6, 7, or 8, we can kind of use that to predict what the future looks about. And that's the most important thing about the system, is that it predicts natural history. And we're finding over and over again that it's actually pretty good about predicting natural history, which means that it's really good at helping us help you do goal setting. So it's not an outcome measure. So if people talk about, certain treatments about changing the GMFCS system, and while some certain patients can change and they can move up and down in that's really wasn't what it was designed for. So that shouldn't be really kind of the focus. We use this little pictograph to kind of show it's kind of a quick and easy way. There's pictures that kind of demonstrate what the GMFCS should look like between age 6 and 12. 1, 2s, and 3s are kids that walk. 3s end up needing to walk more with some assistance, or they can use a manual wheelchair. 4s and 5s are kids that are less ambulatory. They might need to do a stander, or they might need to do a gait trainer, or they might need some head support for their wheelchair. These are just some a little bit different pictograms between their 12th and 8th birthday, just to kind of demonstrate that as we get older, sometimes we need a little bit more support, but it really doesn't change their functional classification system level. So we'll shift gears a little bit to kind of talk about that, how CP really kind of changes really as we go through our adolescence. And so we know that we have these primary issues going on with kids with CP. They have abnormal muscle tone, either they're spastic or they're hypotonic or they're mixed. That leads to some muscle imbalance. And we also know there's some weakness issues. But when you throw that in with we know that there's some developmental delay, and we know there's some activity limitations, you starting to get over here to the effect of growth and muscle contracture. Eventually that leads to some bony deformity. The bones actually literally twist and change shape over time as a result of all of these things in growth. And that can lead to joint problems. And then when you kind of combine all those things together, that's where we really get some of the functional impairment with disability. We can have pain, and we can have potentially some degenerative joint disease or arthritis. And that's what we want to prevent. So now to talk about hips in particularly, most kids with neuromuscular hip dysplasia or CP hip dysplasia, it's very, very different than the classic hip dysplasia that your pediatricians were testing on. Kids that are born with their hips out of socket are in a term of dysplasia called developmental dysplasia of the hips, or DDH. And those are kids that, you know, typically don't have any other developmental delays. They have just a pathological, they have an anatomical problem with their hip joint. However, in CP, most of those babies' hips are born normal. So it's important to know about this, that literally the hip kind of grows out of the socket, and it grows out of the socket because of all those other things that I was telling you about before. Here's just a set of x-rays that kind of show this. This is a X set of, and this is old because it's in a textbook, but they were able to follow this kid really over 10 years and show this picture. Here's an x-ray that shows essentially a normal hip in a 2-year-old, but you can see that that hip kind of starts to head out of the socket. It's kind of going out that way over time. And it's a combination of things that drive that. Some of our developmental delays leads to this persistent primitive hip architecture. And then they have normal growth, but in the normal growth in the setting of any spasticity or muscle imbalance, that can kind of lead to even tighter muscles. So it's a downward spiral. This muscle imbalance with some of our muscles that are really weak and some of them that are too tight can kind of lead to that bone twisting. And then that can lead to that subluxation and eventually dislocation. Here's another picture of this here that you can just see, again, very normal at 4 years of age, but essentially down here at the bottom, now when they get older, that it's more essentially a dislocated hip, which can become painful. And I'll talk about that in a minute. So again, this is just kind of another way of saying that you'll hear some of the people, some of the doctors talk about neuromuscular hip dysplasia. They'll talk about some of the things that we measure. They'll talk about femoral aneversion, which is kind of the rotation of the femur. They'll talk about the neck shaft angle, but those things are, are probably not as important for us to focus on tonight. It's more common in GMFCS levels 4s and 5s, and I'll show about what that looks like in a minute. But it's important to note that hip dysplasia can occur even in kids that are GMFCS 2s and 3s, and especially in kids with hemiplegia. We have to really be aware of those kids because it sometimes can be a bit silent. So kind of what happens down at the muscle level? Well, again, everybody who's ever kind of seen a tight kid knows that their groin muscles are really, really tight. And that's these muscles all through in here. They're just really, really tight for that. And then we have this bony deformity. The neck shaft angle becomes too steep. It literally is too steep. And then they get that femoral neck aneversion, or that abnormal rotation. How do we measure that? We literally just measure a migration percentage. That's what you might have heard people talk about, the MP, or the Reimer's migration percentage. That's just the percentage of the hip ball that's out of the socket. That's the simple way to think about that. And in normal hips, if we're talking about a hip that has no abnormalities at all, that number should be around 10% or so. The number that really gets more concerning is typically somewhere between 30, 35, and 40%. Once it gets above that, we start to worry about what the future of that hip is going to look like. So how do we know that about how to predict what hip dysplasia is going to do based on our population? Well, there's been 3 really, really good population-based studies. CPRN's trying to get to where we have better research infrastructure here in the United States. In our Scandinavian friends, as well as in Australia, they have a much more robust public healthcare system where they're able to get a registry of all the kids with CP and then follow them very closely. So because of that, they're able to look at these things, and there's been these very good studies that have looked at this. And this was one of the first ones that did this. And it looked at the percentage of hip displacement or hip dysplasia in CP, and then they plotted it as a function of GMFCS system. I told you before that GMFCS system was really, really important to kind of help us plan the future. And that's what we're talking about here. There's not a lot of things in life that are as linear as this is, but this is one, the relationship here and the math behind this is one straight line. Kids with GMFCS1 function really have almost a 0% chance of getting hip dysplasia, but you see it goes up by the GMFCS level. So by the time you get to 4s and 5s, you got between a 70 and a 90% chance of having problems with your hips. So that's really important as we're meeting somebody for the first time. That's why it's important that we determine what the GMFCS system is, and we try to come to a consensus about what that is, because that helps us predict what their risk is about hip problems in the future. So I'll talk a little bit more about hip surveillance a little bit as well, but I wanted to talk about talking to parents and to patients. I want to talk a little bit about how we treat hip dysplasia, because that's an obvious thing. It's great that we find it, and hip surveillance allows us to do that. What do we do once we find it? So there's 3 different types of surgeries that we do to treat hip dysplasia. First of all, it's kind of been shown that really any type of conservative treatment, bracing, Botox, they really don't make a huge difference in the natural history of whether those hips stay in place or not. So once that hip starts to kind of head out and that migration percentage starts to go up, conservative treatment really doesn't work that well. Once it gets up to a certain threshold, then usually we're unfortunately having to recommend surgery. So the first thing is preventative type of surgery. And that's where we might do some tendon lengthenings. We're also doing some growth modulations that's fairly minimally invasive and novel, trying to prevent the need for bigger surgeries. So oftentimes kids will need to have the big hip surgery that you hear about, which is a reconstructive surgery, which is usually an osteotomy, or we cut the bone. I'll talk about that in a bit. And then there's also some hip salvage surgery, and I'll mention that a little bit, especially in the context of adult hip care. So when we see that the hip is really progressively subluxating, we see them frequently over time. We're plotting out what that migration percentage is. Once that percentage gets up above 40 and the kid is really of an appropriate age, then we're usually recommending to do a hip reconstruction, which is usually a combination of soft tissue and bony reconstruction. What do we do with that? It's called the varus derotational osteotomy. I'll explain what that is. That's cutting the femur. And we also do a pelvic osteotomy. We also do some soft tissue work there too. So again, I mentioned that the thigh bone and the hip joint was actually too steep. So the varus actually changes the angle of the hip so that it goes into the socket better. And then I also mentioned that some of these kids have increased femoral anteversion, or rotation of the thigh bone. That's why their thighs rotate in so much. When you correct that varus and you do this osteotomy, you can often derotate at the same time. So you can kind of correct 2 different things at one surgical encounter for that. So what are the results of reconstructive hip surgery? Well, I took over for Dr. Freeman Miller here at DuPont. He is really considered one of the American giants and pioneers in the care of children with CP. Literally wrote the textbook, Cerebral Palsy, that is kind of considered a Bible, surgical Bible for how to take care of the kids, give surgical treatment for kids with CP. So he was here at DuPont, started the CP program here. This classic paper was really one of the first things that was done back in the 1990s. Not only did he look at x-ray results, but he really asked the parents what they thought about the surgery, which was really pretty novel at the time. We're trying to do that much, much more frequently now. The network certainly is very much invested in getting our patients and our families' input on our research and what we're doing. But back then it was pretty novel. And he found really excellent results after this surgery. The hips were able to go back into the socket. They stayed in the socket for the most part. And that 80% of the caretakers thought that the procedure was very beneficial. We now have some more modern ways of trying to assess that, rather than just asking the families, do you like it or not? And so there's a tool called the CP Child, which is a patient-reported outcome measuring quality of life that was created by Uni Narayanan, one of our key members in the network. And we now know that hip reconstruction improves quality of life scores in kids with CP. And we can actually go right back to that migration percentage that I mentioned. We know that before the surgery, kids that have a higher migration percentage, means that the hip is further out, they have lower quality of life scores by measured with CP Child. And now we actually, thanks to Ben Shore and some of his group up at Boston Children's, we know that after hip reconstruction, those scores go up. So this is really one of the first pieces of evidence that we've had to really show definitively that we're really making a big difference in these kids when we're doing the hip reconstruction. If you've ever gone through hip surgery, you know it's a really, really big deal. And I'll talk a little bit about that, about our own personal journey with that. And one thing that people often will bring up when I start talking about it is that they've heard other families had it done and then had to have it done again. And certainly there is a revision rate that is higher than what we would like to have. If we have to do this surgery when the kids are really young, all of those things that are still, remember my chart showing all the things that caused the hip problems in the first place, they're all still there. And so if you have to do the surgery when they're really young, that growth still kind of kicks in and you might have to do it again. The overall revision rate from that Boston Children's study series was around 37%. And that was pretty high. And what they found was that they had higher revision rates with lower age. Again, so if you're having to do it really, really early because the hips are pretty bad, you have a higher chance to do it. You also had a higher revision rate with higher levels of GMFCS. So the 4s and 5s, the 5s did a little worse, having it had to have it redone again compared to the 4s, and the 4s did a little worse compared to the 3s and so. But one of the really interesting things that came out of that study was surgeon volume. That was a strong predictor of surgical success. And certainly, I think that's a really, really important thing to ask your surgeon and to talk about that. And, you know, most surgeons who are doing the right thing by caring about their patients are going to talk going to be upfront and talk to you about how many of these things you do a year. Is, you know, there's been clear literature and things like hip and knee replacements and shoulder replacements that the more you do a year, the better you are. That's just human nature. Anything that we do a lot, we get better at. And so I think we've kind of seen this in the pediatric orthopedic world, that you know, places where they maybe don't do this surgery quite as much don't probably have quite the same outcomes as places like DuPont, where we do this, you know, every single week. So it's just, I just say that to just, I always say that when we talk to families, just to look carefully about that and choose wisely. So I'm kind of switching gears a little bit to kind of talk a little bit about adult hip issues in CP. And there's a lot to unpack with that. So it's thought that hip dysplasia only worsens in childhood, that once you're kind of done growing, you got what you got, and then it's not going to really change much over time. So, you know, so if that's true, and then by the time an adolescent reaches adulthood, then they likely will have one of three scenarios, right? They either went through and they were one of those fortunate people who really had no or really mild hip issues. And you can really tell those folks that they're unlikely that they're going to need any future hip treatment. Or they had some hip issues and they had an appropriate hip surgery to correct the dysplasia. And maybe they didn't have a recurrence and they were able to get the hips in the socket. Or naturally, the third thing is that maybe their hips were untreated or were undertreated for their hip dysplasia, and then they're at risk for having some future hip problems in the future. And we'll talk a little bit about what that looks like. So for those untreated and undertreated hip dysplasia, usually the adult treatment is some form of salvage surgery. And I'll talk a little bit about why that is. There's not a lot of adult surgeries that are happening that are actually kind of putting those hips in the socket. And I'll tell you why that is here in just a minute. Now, I mentioned before that it's thought about hip dysplasia that only worsens in childhood. That's really just kind of has been expert opinion. It's really, really hard. The transition from pediatric to adult care is really hard for a lot of reasons. I have a whole talk that I talk about adult orthopedic transition to adult orthopedic care for adults with CP. But we don't have great research to know that. So hot off the press, we have some recent DuPont research that suggests that borderline hip dysplasia, so even hip dysplasia around 25 to 30%, we've got some data on some of the adults we've followed here that can worsen into adulthood. So there's guidelines for doing hip surveillance, and I'll talk about that in a minute about how we look for hip problems in children, but there are no guidelines about how you look for hip issues in adults. So we're really excited about this research because this will really be one of the first pieces of evidence that will go forward to try to make a little bit of some better thoughts about how we can monitor adult hips. Okay, so what happens to an untreated hip dysplasia? What happens when that hip has been out of the socket for a long time? So if you see here, this, your femoral head is a ball and socket joint. That's what your that's what your hip joint is supposed to look like. But when it's out of the socket, there's just some abnormal things rubbing on it. It may be rubbing up against the side of the pelvis. The muscles may be rubbing on it. And that leads to arthritis, degenerative joint disease that can be pretty painful. So I promise I don't have a lot of gross surgery pictures here or anything, but I did want to show a couple of pictures to just drive home this point. How painful are these hips? Well, the previous literature is really unclear. Back in the 70s and 80s and even 90s, they went and they wanted to know how painful were dislocated hips in adults with CP. And they really looked at institutionalized patients, unfortunately. So it really wasn't very good research. This is a picture of what your femoral head, your hip joint should look like. It almost looks like a cue ball, right, on the pool table. It's really nice and glistening and very, very smooth and very round. That's what it looks like when it's kind of been dislocated for a long time. There's a huge divot that has been worn away. So it's really, really hard to imagine that that's not painful. And in our experience, in some of the modern literature shows that there is definitely a relationship between hip dysplasia and pain. So that's why we do hip surveillance. That's why they have formalized hip surveillance programs in Australia and Scandinavia. Canada's starting to do that. It's a little bit hard to do that with our US health system. The American Academy of Cerebral Palsy does have a recommended hip surveillance program, but it's not a true surveillance thing. It's really kind of a recommended radiograph schedule or x-ray schedule saying your doctor should follow this recommended guidelines, and ever so often, depending on GMFCS level and depending on what their hips look like, that kind of dictates how often they get hip x-rays. And so most of the network is actually involved in some types of hip surveillance like that. Paul mentioned that I'm the QI leader for hip surveillance for CPRN. And what we're doing is we're just trying to figure out how everybody does it a little differently right now and try to come together and make sure we're all talking about it in the same way. We're all measuring GMFCS, and then we're actually going to all follow some type of surveillance program. So that's where that comes from. But what happens when it gets too bad? So what happens again in adulthood if that hip's been out of the socket for a long time and it's really starting to get arthritic? Well, you can't really put it back into the socket then. That's the problem with this hip surgery. We often will operate on children that aren't in pain yet because we know that it's going to get worse down the line. And once it gets that painful, the hip reconstruction just doesn't work. So there are some things that we can do. Here's just one more last picture to show that big divot and wear. Again, hard to believe that doesn't really hurt. So the treatment options then for adults with this chronic hip dislocation are really pretty limited. And what we usually do is we usually just kind of remove the hip joint. So again, this is mostly in non-ambulators. And by the time it gets to this point, they're really not getting in a stander, unfortunately, and not getting in a gait trainer, although I have had some patients still be able to do those things after these salvage surgeries. We've looked at them using CP Child and PEDS QL. It does improve their quality of life, but usually by the time you get to this point, they're usually in a significant amount of pain. What about total hip arthroplasty, about just replacing it? That's certainly a possibility, and some places are doing it, and I'll mention that. But it's technically, there's a lot of pitfalls for this in adults with CP. First of all, their hips are markedly abnormal. So the geometry of the hip really doesn't really fit for normal hip replacements. And then they usually have some pretty weak bones. So the implants can get loose or they can fracture, and then they have spasticity. And so often these will dislocate. Dr. Leon Root from HSS in New York actually was a pioneer in this and kind of has the largest series in the literature, mostly in ambulatory adults with CP, and showed that in the right setting, you can do some hip replacements. The Mayo Clinic just released another series in a matched cohort. And this is mostly ambulatory folks as well, 2s and 3s mostly. And they noted that overall they did pretty well, but they did have a little bit higher dislocation rate than what their standard total hips are. So if you're an adult with CP and you're having a hip problem, where should you have these surgeries done? Well, the problem is that adult hip and knee surgeons are not really trained on how to take care of adults with CP, and pediatric orthopedic surgeons who are experts at CP really don't know how to do some of these complex hip replacements. So, the salvage surgeries probably should still be done by pediatric orthopedics. There are some pediatric hospitals with these adolescent hip programs, and ideally, you'd probably want to be able to work in go to an environment where you could work on it together. Where should they be done? It's probably a little bit less critical because you don't really need them than say a spine question, because an ICU admission is unlikely, but still you have to address some of the medical issues. And so you want to be at an adult place that is definitely at least used to taking some care of adults with disabilities. And it's probably more implant related because this won't be a run-of-the-mill hip replacement that can be done in a community hospital. We've just sent one of my adults to Mayo actually to get their hip replacement done next month. What about post-op? Well, the rehab is not that much difference between adolescents and adults, but you just kind of have to think about the social issues, and case management is really crucial for discharge planning, because our older patients, when they're having a hip surgery, they might need an extended rehab stay or perhaps even a short stay in a skilled nursing facility. So wrapping things up about my family, I try to teach our residents to avoid marginal surgery. We really don't recommend surgery unless we think there's going to be a really significant impact to that patient's quality of life. Don't treat the x-rays, treat the patient. Recovery is hard, and so we don't want to do something that's really not really needed. I always try to tell folks not to overpromise the surgical results. There's a lot of things going on with CP, right, that has issues with balance and coordination, and orthopedic surgery really doesn't change that. And so I always just really try to help our families focus in on exactly what we're looking at and looking for out of the surgery. And so, for my own kids, I want treatment options that improved our kids' quality of life with some good surgical procedures and good measures of outcomes. I think we've come a long way, even in my career, towards that. Here's a picture of Benjamin. He was 12 years old. He's GMFCS 4. He had a history of unilateral adductors and had Botox several years, and got weekly PT and solid AFOs and got in a stander. Really didn't have any hip pain, but we had watched his hips just kind of slowly migrate more. So he had bilateral hip reconstruction. And then 3 years later, he had his spine fusion. And, Benjamin is verbal. And so he's able to tell us, he's like, he sits better after his spine fusion, and he's happy about that. And he says he's really, although he wasn't happy at the time that we did his hip reconstruction, he is able to say now as an adult, 24 years old, that he's glad he doesn't have to worry about his hips being out of the socket or worry about bad hip pain. So that's all I've got in terms of slides, but I think we've still got a good bit of time for some questions, Paul. And
we do.
That was informative.
I think that was great. I mean, we have 61 people online. People are very interested. Since we have so many people, I am going to ask that we do this by raising hands. And I'm going to ask you, we've attracted a lot of clinicians and therapists and whatnot. And I'm going to ask that, if you've got questions as a clinician, you probably have access to Dr. Shrader next week at AACPDM. Let's let people from the community raise their hands and ask questions first. And I'm going to read a question that is the last question that was placed in the Q&A, and people can start to raise their hands, and then I will call on people and you can unmute and ask your question. Susan Picerno asked, what about those of us whose hips aren't dislocated, but the hip joint is at the wrong angle and the hip muscles are so contracted and immobile?
Yeah, so obviously we couldn't talk about every scenario in this quick time frame, trying to cover this all there. There's a lot of things that would go into that evaluation, as if you've had hip surgery in the past. Certainly there's, I talked about how hip reconstruction was this great operation, but we don't have great research where we've really followed those kids out for 20 or 30 years from that. And I have seen some of those kids who we get the hips in the socket, but they still get arthritis, and those muscles still can hurt from that. So, it kind of depends a lot about your functional level. And so it's certainly possible that could be going on. And, so probably ideally you want to probably make sure you're seeing a good orthopedic surgeon who's able to take care of that.
Great, thanks. Brittany Lopez,
It's
you're
easier
up
said
if you
than
want
done. I know for adults, I know that.
Brittany Lopez, you're up if you want to unmute and ask your question.
Hi, thank you for all the information. It's really helpful. I have a 4-year-old who's post-SDR, non-ambulatory, borderline level 3, level 4. What do you suggest best to prevent? We don't have any subluxation. We have some coccyvalga, but what do you suggest to try to prevent?
Yeah, I think that's a great question. And it's a frustrating question for parents because, it's like, what you ask, what can I do to prevent that? The question about, like, does the rhizotomy protect against it? Because you've taken away some of the spasticity. And it's such a multifactorial problem because for our children, for our typically developed kids, our normal babies, for their hips to develop normally, they have to have all these things acting on them. They have to have normal muscle tone. They have to have normal development and forces acting on the hips and normal growth. And so we don't have something that we can tell you that if you do X, Y, and Z, unfortunately, you can prevent that. I would say you want to try to stay as active as possible. You want to try to maximize their functional potential. And then with that, it kind of goes and follows along that not every GMFCS 3, right, is going to have hip dysplasia. But I do think someone who's a 3 borderline 4, you need very close hip surveillance at a place that is really good at doing hip surveillance because those things can change over as you go through growth.
Okay, that's helpful. Can I ask a quick follow-up? How much do you think standard time?
Yeah, that's a great question.
Yeah,
and even there is some very early literature that suggests that maybe standing and abduction might change the trajectory for some of our hips. I would be 100% supportive if we had population-based evidence to say if you stand in a standard 2 hours a day, you decrease your risk of progressive hip dysplasia by X%. We don't have that data right now. So it's a lot of really, really small series that are done by some really, really smart people, but don't really have the research behind it yet to really kind of tell us that. I think standards are great for lots of reasons. And so I think, you definitely should be pursuing time in a stander and time in a gait trainer for the functional benefits and also for a lot of the benefits. Avoid contractures, healthy bones, even helping GI problems and things like that.
thank you.
Okay, Christina Zapata, you're up. You can unmute yourself.
Yes, my question is I have a daughter. She is 10 years old and well, her hips looks really good. Actually, for 10 years old, we've been just having the checkup every 6 months and they say that they're still in place. But she's not doing standard as much as she should. Do you think that can affect her just to have any dysplasia later on if she doesn't go in their standard or do the peanut ball as she used to do?
Yeah. So again, kind of follow up with that other question. We don't really have evidence to say that, not going in the stander is going to make your hips worse. We don't have that evidence, just like we don't have the evidence to say that being in a stander a certain amount of time is going to help your hips. I think in general, being in a stander is helpful for all those things I mentioned. It is natural as kids get a little older. They, especially as they're able to give their preference, they may not like to get in the stander as much. It may be a little bit uncomfortable, but I do think you should still continue to still emphasize that. One thing I would just say is that I encourage all of you to ask your doctors what your migration percentage actually is. What's that number? And then, you just keep track of it over time, because sometimes folks will look at x-rays and say they're okay and they're in the socket, but their migration percentage might be 30%. That might be very important to you because you know that a 30% migration, while that's not bad, it's certainly not at surgical level. It's something that you might be worried might get worse over time, and you want to continue to advocate for close surveillance.
So, Wade, if I can just ask, I know it could be awkward, so I'm sure I hope there's a way to answer this. But if you're seeing someone and they are surveilling, but you get to the 30% line and they take no action, what would the advocating be? What would you recommend someone say to their provider?
Well, so, I mean, I think, 30% is, is still not necessarily surgical, depending on the age and the function and all of the child, but it's getting close though. Right. And so, I guess what I just think it's important to know that, that okay hip, what that actually really means and what that percentage really looks like.
Okay. So Poonam, you're up next. You can unmute.
Thank you, Dr. Shrader. It was very informative talk, but very scary too.
Yeah, I'm sorry. I definitely don't mean to scare, but I also want to be very truthful about it.
Yes. So thank you for making us all aware of this. And my son is 23, and we are one of those cases that has fallen through the cracks with the transition from pediatrics to adult. So, and then with, physicians retiring, and there's no way you said, the pediatric physician can work with the adult physician. All that has kind of just fallen through the cracks.
It's a very hard time for most people. It really is hard.
And even when we were going to the orthopedic surgeon, the philosophy was not to do x-rays very much. And they were focusing more on the function, how he's walking, and how the gait is and all that, and more like gait analysis. So what kind of hip surveillance, like right now we don't have a physician, so what kind of hip surveillance should we be looking for, or who would be the person doing it? Like he gets physical therapy, so the physical therapists are definitely watching him, but that's about it. And a physiatrist.
Yeah, I think you ask, there's a lot of complex things in your question there, right? So transition is hard. Trying to find a doc who's an adult doc, but also is familiar with cerebral palsy is incredibly hard. We don't have, there is zero evidence that talks about what we should be doing about hip surveillance in adults. And in even older adolescents, the thought is that once you get to be skeletally mature, so 16 for boys, typically, your hips are not going to get worse after that. And so that may be why they weren't getting x-rays. And it also depends on what your hips were like, how close they were, did they have hip surgery? Is the migration percentage 10 or 15%, which is near normal? So you probably don't want to do radiographs as much with that. But what we found kind of concerning in this new series was that those borderline kids that went off into adulthood, some of them really got worse, even into, older adolescence and adulthood. which we think is going to inform our ability to come up with better protocols for hip surveillance. Paul mentioned Dr. Roy, who's in China now. David has long been an advocate for extending surveillance into the adult years as he created his adult clinic at Columbia. So we don't know, but I would say I would try to find probably the best bet. I don't know where you are, but the best bet probably for adult musculoskeletal care in most settings is a rehab doctor, a physiatrist. And just be frank and ask them, just say, hey, we've been worried about it. He's had hip problems in the past, or there's been some hip concerns, and whether we should measure that.
Okay. And functionally, what are the symptoms that we would see if it was getting?
Usually pain in adults would be the issue. Hip pain in your groin, mostly. Maybe the buttock, but mostly the pain in your groin.
Thank you.
Okay, so I think we've maybe, depending on how the questions go, time for 2 questions. So I appreciate everybody being as succinct and maybe getting 1 question in. David Daniluk.
Yes, Wade, really enjoyed the presentation. My question is, what does the role of braces play?
Yeah, so braces in the setting of hips don't really do a lot. And it's because it's very hard to try to control your pelvis and get your hips in the socket. As you brace one side, you end up kind of getting a little bit windswept, and you actually it probably doesn't help very much. They did do a little bit of research on looking at bracing after Botox. And again, it probably didn't help very much. Dr. Miller, he hated bracing around the hips. So we don't even do it much after surgery, but probably not very helpful.
Okay, thank you.
And then last question tonight, Amber Gorman.
I was wondering, in adults that are ambulatory, that I'm assuming that, that we don't have normal, we might not have subluxed hips or hip problems, but the depth of the socket is not the same, I would imagine. And so how does like aging and osteoporosis and muscle mass loss, affect that? And how would the hip be treated in ambulatory people?
Yeah, so that's a great question. So probably osteopenia probably does change the hip architecture. I mean, it may increase your risk for fractures and things like that. If you have subtle hip dysplasia, it's a little bit like your wheels are malaligned on your car, which may mean that you're at increased risk of arthritis down the line. But if it's subtle hip dysplasia in an ambulatory adult, then they'd probably treat them if that became painful with like a hip replacement. But you probably wouldn't want to go through any type of osteotomy to try to make those angles normal. You'd probably just wait and see, depending on like any other older adult. Hip dysplasia is, adults can have hip dysplasia that don't have CP. There's another form of hip dysplasia, and it's the #1 reason why adults in the US get total hips under 50. So you might have to get a hip replacement in that setting, but only if you started having hip pain. I wouldn't suggest you changing your activity levels or anything like that, being worried about that. Typically in that setting, that migration percentage is going to be like 20% or less. It's not going to be borderline going to be that worrisome. And then,
but I think you said that hip replacements, we don't do as well with hip replacements in general because of the structure.
Especially GMFCS 3s, 4s, and 5s don't do quite as well. 1s and 2s do maybe close to the same as someone without CP. It all depends. It's really probably a linear relationship, just like hip dysplasia is with that. It depends a little bit about spasticity and all. I would say, again, if I was a GMFCS 2 with hip problems, if my son, one of my sons is GMFCS 2, if he had hip problems, we would go to a center that was a high volume arthroplasty center that had some experience in doing adults hip replacements in CP. I wouldn't do that type of hip replacement at my community hospital.
And if you have like, if you're, you have the other joint deformities like valgus or varus, the hip replacement wouldn't affect that, or how would it affect that?
It all depends on the degree of it. If most folks who are ambulatory aren't going to have severe say coxavalgus, and hopefully they wouldn't have any coxavera either. That's the varus deformity. But if you do have other issues about that, then, sometimes those do need to be addressed if they're severe, and they're throwing your mechanical alignment out.
Okay. I'm going to stop you from more questions at this point, Amber. I think Dr. Shrader has been incredibly generous with his time. Way to get an award for the number of people that signed up, broadest array of parents and adults with CP, and a lot of clinicians. Probably have a little bit of Ginny to thank for that, but so this has been great. This will I'll let everybody know about the recording. Greatly appreciate your time. Go say hi to Carol, and have a great evening. Thank you so much. Thanks everyone for joining in.
Thank you both.
Thank you.
Thank you.
Bye.
Thank you.
Bye, Wade.